You know what is AIDS, right? Acquired immunodeficiency syndrome. So basically, it is when it affects your entire immune system. Your immune system is gone. So there are T helper cells, which actually is a part of your immunity, cell mediated immunity, which is fighting against everything that is attacking your body, whatever it is. This is what is giving you protection. But when your immunity is slightly low for other reasons, then you can give maybe you can give steroids, or you can give something to help boost the immunity. But in this case, it's crashed. It cannot be revived at all, and that is the reason why it is so bad. And when your immunity is that low, even the simplest of infections can be morbid for you. Okay, so that is the reason why it is undergoing a lot of studies, and they're trying to find a proper cure. So how did humans acquire HIV? So HIV was not seen. HIV is a human deficiency virus. Okay, so that's the virus which causes the AIDS, that is acquired immunodeficiency syndrome. Okay, so when we say HIV positive, we are saying that the person has HIV virus in his body, but that does not mean that he has AIDS. So AIDS, I will show you when he has that complex of disorders associated with him. That's when it's called him or her. It's referred to as AIDS. And it's a syndrome. It's a syndrome. That's why it's a complex of syndromes. But the virus which causes it is HIV. Okay, so when you say HIV positive, it's the virus which is present, might not have still acquired the syndrome. All right. So earlier it was seen only in animals, and it was seen in apes or simians. That's why it's called a simian immunodeficiency virus. So it was seen in those animals. And how did it become HIV? And HIV is for humans, right? Human immunodeficiency virus. So how did simian immunodeficiency become human immunodeficiency? There are several theories which were proposed. So the first and foremost theory was the hunter theory. So whoever had either a passion for hunting, or I shouldn't even use the word passion, I mean, who indulge in hunting as a form of recreation, which is pretty sad. So those people, when they come in close contact with these animals and the blood they acquired, the disease, the colonialism theory, when people were colonized, and when they had to live in like very close quarters, together. So during that time, there was the spread of this virus from animals to the humans. When they were all together in huddled in very unhygienic areas. Then oral polio vaccine theory is that how a vaccine is prepared. You inject the antigen in an animal, you produce antibody, and then you take that antibody and you give it to a healthy person so that immunity is acquired. That's how you make a vaccine. So what they did was they were using these infected monkeys to produce the vaccine. So when the vaccine was given to thousands and millions of people later, so that spread the virus, is another theory. Conspiracy theory, this is there, I think, with everything. So the conspiracy theory with COVID, anyone knows what are the conspiracy theories? Okay, let me share with you, because I find it very, very very interesting and mysterious. So the first theory, which started out when COVID broke out, was that it was a pharmaceutical mafia, and the pharmacy wants to make money by making vaccine and everything. And so they created this fear among people, the COVID doesn't exist and all those things. The second theory was Second theory, which is floating recently, is that the world is coming to an end, and all the major governments want to prepare people to face such adversity, which is going to happen, where you might have to stay isolated in your house, and there might be very extreme environment outside where you cannot go out without wearing a mask. So they're psychologically preparing you for something far, far, far worse, which is going to come. So that's one of the conspiracy theories of COVID. So the conspiracy theory of HIV is similar. So the powerful countries, the major countries which have a lot of power in this world, wanted to control the developing or the poorer countries. So they released this virus, they made this virus basically in order to spread it and, you know, to create that fear and chaos among the people. Contaminated needle theory, this was mainly in countries like Africa basically, where you know, the economy is very, very poor. So they would use the same needle to inject everybody, whether it was you know, intramuscular injection of some drug, or whether it was a vaccination or whatsoever. So they were reusing the needle. They were not using a disposable needle. Since the advent of disposable needle, a lot of such cross infections have been controlled, but in poor countries where the resources are not that much, financial resources, so they use those undisposable needles, where they sterilize the needle and reuse it. And if the sterilization is not complete, and if there are a lot of people waiting in the line, they reuse the needle. Then that's how there is a spread of the infection. So these are all different theories of how it spread from. Oh, by the way, the word zoonosis means when you get when you contract some infection from animal. Okay, when a human gets something from animal, it's called zoonosis. So why, as dentists, it is very important is because the oral signs and symptoms is the first presentation of AIDS patients again. Okay, so that's we play a major role in identifying it, and it can also predict progression. So when I describe to you all the diseases which are present, it also predicts the progression of the AIDS itself. So there are different staging and classification systems which say what are the important markers. So according to them, oral candidiasis, which we just finished in the last class, is a very important clinical marker that we're going to study, especially the type of oral candidiasis, which has significance. Apart from that, there is oral hairy leukoplakia, herpes zoster, and persistent herpes simplex infection. So all the infections which we're finished studying are all very important in manifestation of AIDS infection. It correlates with the viral load, the occurrence of all these diseases, especially the oral hairy leukoplakia and candidiasis. And they also indicate the entry and end points in the therapy. When the patients are being treated, the doctors like to monitor the oral signs and symptoms so that they know when there is an improvement and when the treatment can be ended. So classification, it is broadly classified as lesions strongly associated, lesions weakly associated, and lesions which are associated, meaning there is no prediction of strong or weak, they're just associated. So this is very, very important from your exam point of view as well, and when you go to the clinic. So the first and foremost is the candidiasis. So you can imagine the amount of importance it's been given. And then followed by hairy leukoplakia, Kaposi's sarcoma, non-Hodgkin's lymphoma, and the periodontal diseases are the linear gingival erythema, necrotizing gingivitis, necrotizing periodontitis. This word is no more used, ulcerative, it is removed. This is the older terminology when they were using ulcerative in between, but now it's called necrotizing gingivitis, necrotizing periodontitis, very important feature, and linear gingival erythema. Very important features seen very classically in patients with HIV. So these are the lesions strongly associated, and these are the ones which we're going to discuss today. Whereas we also have lesions less commonly associated or weakly associated, we say. Bacterial infection, that's your tuberculosis, and Mycobacterium avium intracellular, which spreads by the birds. Melanotic hyperpigmentation, necrotizing stomatitis, salivary gland diseases like xerostomia and bilateral swelling of the glands, thrombocytopenic purpura, ulceration which is not otherwise specified. There is just ulceration without any cause behind it. And of course, the viral infections like herpes simplex, human papilloma, and varicella zoster. And lesions which are seen in HIV, like I said, it is associated, but it does not have any strong or weak association with it. Are bacterial infections, cat scratch disease, drug reactions. You can just go through the list on your own. I will move on with the lesions which are strongly associated with HIV infection, and most of them have oral manifestation, hence it is very important to us as dentists. I don't know if you can see, I just couldn't make it better because I wanted all of them in one slide, and this is the best I could do with it. I'm sorry if it is not very properly aligned. So these are the different types which we have already discussed last class, right? So there is pseudomembranous, that is acute pseudomembranous, then acute erythematous, chronic hyperplastic, and then there is angular cheilitis. So the form which is associated in early lesion is the erythematous type or the atrophic type, whether it's acute or chronic. Both of them are associated with the early HIV. The one which shows a progressive immune deterioration is the association of the pseudomembranous type. I'm not discussing the appearance because we've already finished it. I'm only telling the significance, okay? And this is the most classic, the hyperplastic, the chronic hyperplastic variety, or the leukoplakic variant, if you remember from the last class. That's what is associated with the most severe immune suppression and gives an alarming sign when you see it in the patients with AIDS. And angular cheilitis is seen in all stages of HIV. So that was the first lesion, which is strongly associated. The second lesion, which is strongly associated with HIV, is hairy leukoplakia. This I've mentioned briefly when I was talking about leukoplakia, that is a pre-malignant or the potentially malignant lesion. It is caused by Epstein-Barr virus. It's a viral infection, basically. It is well demarcated white lesion. It is non-scrapable. That's how you will differentiate from the candida. And there is a varied clinical appearance. It can be plaque-like, it can be flat, it can be papillary, filiform, or corrugated lesion. It can have a varied appearance. It is either unilateral or bilateral, but the classic appearance is the area which it affects. It is seen on the lateral margins of the tongue, which is the most favored site. Of course, it can occur elsewhere, but most common site which is affected is the lateral borders of the tongue. Histopathology, like I said, most of the viral infection will show this ballooning degeneration, okay, with the nuclear bleeding. So you can see all these cells which are undergoing ballooning degeneration. There is hyperparakeratosis, which you see on the surface of the epithelium. And there is acanthosis. Acanthosis is increase in the prickle cell layer or the spinal, you can see here. Thickness is increased, and there is edema as well, which is present between the cells. And within the cells, you will see viral inclusions, if you can notice here. So these structures which you see inside are basically virus, and their inclusions seen within the keratinocytes. So you say viral inclusions within the keratinocytes. The next lesion, which is again strongly associated with the HIV, is called as Kaposi's sarcoma. So it was, of course, named by Kaposi. That's why it's called Kaposi's sarcoma. It is a very rare vascular tumor, and it is usually seen in European populations. but it has a very strong association in patients with HIV. So it need not be Europeans when it is seen in HIV patients. It can occur in any population. So the etiology is the virus behind it is HHV8, and that is human herpes virus 8, or Kaposi's sarcoma herpes virus. So that's the short form of that. Clinically, it affects the palate, tongue, and gingiva. In the beginning, it is flat, but later it can become exophytic. I hope you know what's the meaning of exophytic. It has outward growth. Can be single or multifocal. The color is very classic because it's a vascular tumor. It is either red or bluish in color. There will always be blanching on pressure when a blood vessel is involved. Remember this. Anywhere in the body, any kind of lesion, wherever the blood vessel is close by, there is a blanching on the pressure. And there is a pain, bleeding, and necrosis will be seen in association with these lesions. You can see the amount of destruction that it is capable of causing. And this is the histopathology. I think the classic is this is the early lesion, which looks quite benign. In fact, it doesn't look that malignant, with very few dysplastic features, and there's a subtle increase in the capillaries. But this is what we see in the advanced lesion called a stag horn appearance. So it looks like a horn of a stag basically, and there are a lot of spindle cell proliferation, and the capillaries will take up a bizarre shape. Bizarre shaped capillaries are seen everywhere. The differential diagnosis is hemangioma. It's a benign tumor of the blood, so you have to differentiate whether it's benign or malignant. Erythroplakia, because of the clinical appearance of occurrence. Melanoma, because of the bluish and the site as well. So because of that, you must differentiate the two. Even the type of growth, the progression is similar between melanoma and this. Pyogenic granuloma, which is a very common benign tumor seen in oral cavity, might have a similar appearance, and even the site on the gingiva. So in such cases, you have to be very careful to differentiate the two. Even that shows numerous new capillaries which are developing, and you have to be careful. Bacillary angiomatosis is another lesion. So it's the importance behind identifying whether it's a sarcoma or whether it's a benign tumor is to decide your treatment. I hope you know that by now. Next is non-Hodgkin's lymphoma. So non-Hodgkin's lymphoma is a relatively late complication of HIV infection, and it affects the gingiva, facial pillars, and palate. These are the areas which are affected. There is a rapidly growing soft tissue mass, which is non-tender, meaning there is no pain, and it is diffuse in its spread. It can be boggy. Boggy means it's not like firm, basically. Okay, erythematous, purplish, and it can be either ulcerated or may not be, depending upon whether there was trauma or not. And it can even have intraosseous involvement. Osseous, you know, is the bone. Intraosseous means inside the bone. And when there is an intraosseous involvement, it can resemble diffuse progressive periodontitis. That was non-Hodgkin's lymphoma. Another type of lymphoma which is seen strongly associated with HIV is Burkite's lymphoma. Maxilla is more commonly affected, twice more common than the mandible, and posterior jaw is affected. Here we are seeing mandible, but maxilla is more commonly affected, and posterior area. There could be facial swelling and proptosis. Proptosis affects the eye, drooping of the eyelid. Pain, tenderness, and paresthesia can be seen. Paresthesia is partial anesthesia, which is transient feature. There will be numbness in that area because of the pressure which is applied upon the nerve. but once it is relieved, then the patient will regain the sensation in that area, and that's why it's called paresthesia or partial anesthesia. Tooth mobility in that region wherever the tumor is involved. So if the tooth is present there, then it exhibits some grade of mobility. So in histopathology, there are sheets. So I've described to you, whenever you're describing histopathology, I've told you that you have to describe how the cells are arranged, okay? It could be nest-like, island-like, they could be arranged in tube-like structures, cord-like structures. So this is a sheet-like structure because it is present like sheets of cells. They're large lymphoid cells, and the differentiation is not undergone completely, so you can see that they're immature. Nodular or follicular pattern can also be seen. If you remember from ameloblastoma, the cells were arranged in a follicle or a nodular pattern. So that similar pattern you can see here, arrangement of cells. There is very minimal cytoplasm, and there is alteration in the nucleus cytoplasm. You can see in this higher micrograph image. The nuclei is kind of filling up the entire cell. That's why it's like bluish. So even here, if you see, because the nuclei is what imparts the hematoxyphilic color, right? Cytoplasm is eosinophilic, so it gives the pink color. It's the hematoxyphilic nuclei which gives that purplish blue color. So that's why the entire lesion appears like this, because the nuclei is enlarged and it is filling up the cell. And there is also destruction of the normal adjacent host tissue because of the infiltration. I think there is even like if there is any nerve surrounding in the area, they're also invaded by this. And described as starry sky appearance because of the presence of macrophages. You know, macrophages can have it can be foamy in appearance, and they have abundant cytoplasm. So these macrophages are dispersed between the lymphocytes. Yeah, so these are the lymphoma cells, the blue ones, and these light ones are present in between. So this kind of an appearance is called as starry sky. Stars are referring to the macrophages, and the lymphoma part is the sky, that is the dark night sky. So this is just a higher power micrograph of the same. Coming to the periodontal disease, I'm not going to describe in detail. I've just listed them out. Linear gingival erythema looks like just an erythematous line, which is present right on top of your cemento-enamel junction and on all the teeth. So that's why it's called as linear gingival erythema, seen on all, seen diffused occurrence. Necrotizing gingivitis, the gingiva shows necrosis. So beginning, it starts as whatever papillary lesion or a blister or whatsoever, and then it ruptures to leave behind severe ulceration. So the entire gingiva undergoes ulceration. Necrotizing periodontitis might begin as necrotizing gingivitis and then affects the periodontium around it, or it could begin as a necrotizing periodontitis itself. So as you know, periodontium is your supporting structures, that is your cementum and periodontal ligament and the alveolar bone. So when those are affected, it is called as periodontitis. So there is severe mobility, because when these are affected, it's the teeth support is gone. So the teeth will show mobility, severe mobility, and there will be boggy gingiva on top because it is spread to the gingiva. From gingiva it can spread to periodontium, or it can be vice versa. So all these features we see in the necrotizing periodontitis. Okay. Yes, that's the end, and the learning objective which you were supposed to learn from this class are the importance of oral signs and symptoms, which we finished, related to the HIV, and the clinical features, of the lesions which are strongly associated. So we finished all the lesions which are strongly associated. If you're interested, you can go and check the other lesions which are seen weakly associated or seen in association with HIV. Now you're familiar with these terminologies, that is the balloon cells, acanthosis, increase in the spinocerebellar thickness, nuclear viral inclusions within the keratinocytes, spindle cell proliferation, and starry sky, which we refer to in relation with the lymphoma. Okay.